Good morning, my dear friends from Delhi, Jharkhand, Tripura, Manipur, and all the institutions of Assam. So today we will be talking on a subject which is very important in day-to-day practice, that is about the injury of the thoracic lumbar spine. So in earlier class we have discussed in details about the injury of the cervical spine, its classifications, mechanism of injury, and radiological evaluations followed by treatment we have talked. So today we will be talking something about the thoracic lumbar spine, which is also important, as in day-to-day practice we often get many cases coming to us with the injury of the thoracic lumbar spine. But as usual, we do start always with some philosophy. So last time we have been talking Karaganda karmana siddhi jasanta siddhivata khiprahi manusya loke siddhi bhavaji karmaja. It is the last phrase we have discussed. Today, Satubainnam maya sistam guna karma vibhagasa tachakatrampi nama katrambhyam. So, our Lord says in chapter 4 of Gita, as I said, Gita is not a religious book, it is a book of philosophy. So, he says, Satubainnam maya sistam guna karma vibhagasa tachakatrampi nama katrambhyam. Means the peoples are being divided upon the basis of the karma and gunas in 4 classes. So, it is not by the birth, but it is because of the karmas and gunas. There are 4 divisions of the Guru. That is what Lord says to Krishna. Krishna says, my Lord says to Arjuna, that Satubainnam maya sistam guna karma vibhagasa tachakatrampi nama katrambhyam. So, keeping in mind this thing, we will go ahead with the thoracic lumbar spine. So, thoracic lumbar spine many times associated with some sort of a polytrauma. As you all know, in the polytrauma victim, around say, so coming in the casualty, we need to evaluate the patients on the basis on thoracic lumbar spine point of view also. Because it is seen around 5 to 10% of the cases with polytrauma are having some sort of injury in the thoracic lumbar spine area. That is why it is very important. It is also important that about 40% of the injured case, they used to have some sort of abdominal injury also. So it is not the thoracic lumbar spine is important, but the associated parts are also important to evaluate, particularly ultrasound. That is why the concept of FAST or the ultrasound some study of the abdomen, particularly injury setup, is very important, and it is to actually exclude the abdominal injury as well. It is seen around 40% of these cases. Again, out of these your cases, it is seen around 20% may have variable degree of neurological deficit. So, these patients are not only having the abdominal injury, but also they are having the possibility of some sort of neurological deficit as well. So, this is very important, and we will talk some sort of anatomical features which are important to talk about the thoracic spine. Thoracic spine, as you all know, this is a bit rigid sort of. The mobility is somehow less than compared to thoracic lumbar cervical spine and thoracic lumbar spine. But their rotational elements are more. Rotational part is more common in thoracic spine than that of your lumbar spine. So lumbar spines, the thoracic spine, you will find the design of the diaphragmal joint that gives a liberty to have more rotation rather than that of your other part. So in the lumbar spine, this all because of the fact this is basically due to the fact that the design of the diaphragmal joint. Facetal joint, how it is being designed. So that's lead to your liberty of rotations. Rotational elements are more in thoracic spine than that of the lumbar spine. That is because of design. Few important anatomical points are also important to understand. That the occupancy of the spinal cord in a thoracic level. So it is found that the chances of injury to the neurological structures is a bit less in the lumbar spine and sometimes even thoracic lumbar cervical spine. But the occupancy, the freedom of movement in between the spinal column, and the vertebra and the intervertebral, that is your foramen, vertebral foramen. So the greater part of this being occupied by neural structures. So that is why the chances of injury to neural structure is a bit high in thoracic area than rather that of your cervical spine and the lumbar spine. That is one important point. An important point to understand also that the nerve artery of adjunctus. We all know the circulations is being contributed by anterior and the posterior vertebral artery, spinal artery. But here in this area around the level of thoracic 8 down, predominantly this area is being supplied by this adjunctus artery. So insult to the artery may also have a detrimental effect to the spinal cord, and that may also have a very unfavorable outcome. And so that is also important thing to consider as far as the thoracic spine is concerned. Moreover, we see that this area is more a junctional area between a mobile and the stable component. So that is why the stress strain part is more in thoracolumbar junctional area. We do consider that this thoracic spine is somehow stable, somewhat maybe rigid because of this in context to this thoracic case. So it is relatively stable. On the other hand, it is junctional point having continuations with this that lumbar area which is very mobile. So that is why this area which is fixed and then again mobile part. So this junctional area is always having some sort of stress and strain. So that is why the chances of injury in this area is quite high, because it is a stress riser sort of thing between the mobile and a relatively unmobile part. So it is seen that this mobile segment, the unit segment, mobile segment, we say the segment of the thoracic spine, particularly D11 to L2, this junctional area, particularly thoracolumbar junction, we usually talk, somebody say L1 or L2. Even then, that part, the D11 to L2 part is the more dangerous or more prone to have injuries. So because all the fact is because that this is a junctional between the mobile and the stable joint. This is very understandable. And moreover, if you consider about the incidence of the thoracolumbar spine injury, it is seen that there is some sort of bimodal sort of tendency in this injury. Bimodal in the sense that it is more prone around the young adult, particularly some 30 to 40 years age, because of the high velocity trauma or the road traffic accidents. It is more common. That is most of the time because of your high velocity trauma. On the other hand, in case of elderly patients, because of this unsteadiness gait and because of this your unsteady gait or because of these postural problems, they lead to your many times a fall, and a trivial fall leads to a consequence of the injury at the thoracolumbar junctional area, or it's a compression or whatever it might be, is more common and is being contributed by the age-related osteoporosis. So age-related problems, particularly elderly patients, because of the osteoporosis, because of the unsteadiness gait, and the lack of stability are the contributory factor to having increasing number of the persons in the elderly age group. So this is having a tendency of bimodal sort of injury. So it is elderly, young, it is because of the high velocity trauma, or in case of elderly, it is because of this your trivial trauma contributed by because of your unsteady gait, poor steadiness, and also due to your osteoporosis that leads to conflict. So these are the things which are the background in thoracic spine. And we all know about the thoracic spine is also the stability point of view that we do have three columns. And the tennis columns we all know. This is also applicable here in case of thoracic spine. The anterior column, the middle column, and the posterior column. We have already discussed about the various parts of the component of each column, and Dennis always speaks about the stability point of view that the middle column is very important. Any of the two is involved, with this middle column is a potentially unstable fractures. So Danish column is also being considered there. As far as your fractures mechanism is concerned, the fracture mechanism is now let us talk to a situation where the patient is coming to casualty of the cervical thoracic spine injury. So necessarily, while the patient is coming to the thoracic spine, he is on the spinal board. And our tendency is to do less movement at this area so that the chances of injury to the existing, there is no additions or additional injury to the existing injury. And thereby also the chances of neurological injury or displacement, other things are also curtailed down. That is why the stabilization surgery to be applied. Stabilization. And many times we used to go for the rapid X-ray of the chest because of the primary survey as far as the ATLS guideline is concerned. But many times this is not significantly important, but it is not very conclusive to give the actual picture of the trauma in thoracic spine. So that is why I need to evaluate it with special access later on sometime, even with the X-ray and the X-ray as well as also CT scan on the MRI. That is this protocol. But initial access is not sufficient to give the actual picture of the trauma of the thoracolumbar area. Now, a patient is coming in, what are the possibilities of injuries in this case? As you all know, while we are going through these various mechanisms of injury, we all know that there is sometimes flexion injury, extension injury, there is a translation injury, shifting, then rotational elements, so many things are coming. And on the basis of this mechanism of injury, there is various classification also. But it is true that in today's picture, that none of this classification is very conclusive to tell us, and it is not all are flawless. There are some sort of lacunae to explain all the things and be corporate and give you actual guideline to a treatment protocol also. That is why the classification, McRae classifications or even Danish classifications are not enough to tell us Danish classifications, McRae classifications, and nowadays of course we are more concerned about the AO classifications. All are coming into the pictures, but none of them are conclusively accepted, and there is also inter-observer variations. That is true. So consider this fact that is nowadays, if you do consider about the fractures here, then what classification we are do we consider, and then little bit of your what is your possibility of fractures and what are the different types of fractures we do consider. We all know that there may be some of the compression fractures, which is more common in the elderly patients. Even in young patients also we do have the compression fractures. So one is the compression fracture, while the wedging is there anteriorly and posterior part is still intact. Once there is a break in the posterior contact part here, posteriorly, then it is a burst fracture. And this burst fracture may be stable or may be unstable considering the involvement of the PLC or posterior ligamental complex here. Yes, that is one point. Now, question arises that what about the compression fracture? Is it stable or unstable? The compression fracture as such, if it is happening, the reductions of the vertebrae happening more than 50% of this area, that means if the vertebra height is reduced to more than 50% of the existing one, that is a bad sign, because once there is a compression there, there is a distracting force or there is a tension force working in the posterior structure as well. So it is compressing, it is distracting. So that is why there is every possibility of association of the injury to the posterior ligamental complex. And earlier days, this was correlated with the X-ray finding of more compressions in the vertebra, more the chances of injury to the PLC. That is the correlations, and the correlations on the basis of the X-ray speaks that if it is more than 50% of the reductions of the height, that is a significant point. 1 point. So radiological point of view, what we are talking, and we also talk about the various classifications in this context. But let us talk about the various types of fracture we come across in the thoracic spine. That is one of the compression fractures. Once there is the involvement of this your posterior complex, we say it is a burst fractures. Then again in compression fractures, there is some classifications are coming up, like whether it is superior end plate involved, inferior end plate involved, or bilateral end plate involved. So many things are there in the classifications. There are so many things are there, so that is why sometimes it become confused also, and also unable to give a right directions of these treatment models. So there are so many classifications coming up, even then they cannot direct us what way we supposed to go for the treatment of the. Theoretically it is okay, but it doesn't give a very good directions about the protocol of the treatment. That is the lacunae in the part of your various types of your fractures. Then a sense fracture is there. Sometimes this hemorrhagic and versing fractures translational. So there is seatbelt fractures is there, which a sense fracture is going through the vertebra. Sometimes even the soft tissue also it may go through and through. That is a very unstable fracture. It is staged because of the there is transections between this upper part and lower part, and it is smoothly going from anterior to posterior part. This unstable type of fractures. So what I define as a compression fracture, burst fractures, sense fractures, and on the other hand there is a rotational element of the dislocation also. That means there may be unilateral dislocation or bilateral dislocations and translation also. So translations may, if the translations is more than 2.5 millimeter, it is a significant point of showing the stability of this area. So radiological point of view, the translation is more than 2.5. The reduction of the height of the vertebra is 50% or more, and regional or focal what is called your kyphotic angle is more than 30 degrees. That means if you are doing a average of your compressions between these two adjacent vertebra and compare with that of the involved vertebra, and if the kyphotic angle is more than 30 degrees, is significantly a chance of your stability. On the other hand, there are another modules of the way of doing judgment of your stability and instability is that how the patient's stability instability is being reflected while the patient is standing or waiting. Since the stability and instability actually indicates, by definition, is that once their physiological load, how it is behaving. On the physical load, if it is a translation or the sense is seen, it is indicating that it is a unstable type of fractures. So that is a radiologically, that is why we do application of brace from the sleeping persons. If you are taking a standing view, how it is behaving from the sleeping to standing, and how there is a sense taking place, that really indicates actually the stability instability point, execute the stability and instability thing. On the other hand, the availability of MRI speaks about the integrity of the PLC mostly, and also the other ligamental complex. So today's your judgment or involvement with the earlier days with the help of the X-ray to give the indirect evidence of the integrity of the PLC, and nowadays directly being observed with the help of your MRI, that speaks about the various ligamental complex posteriorly. So certainly while there is an injury to the posterior ligamental complex and also anterior part, that is a sign of instability. So that MRI is also giving us a conclusive pictures about the integrity of the soft tissue structures, both anterior and posterior. We are more concerned about the PLC posterior. Now, these are the various possibility of the fractures that taking place in thoracolumbar spine. That's so most of the time it is happening at the junction of your D11 to L2. This is the most important area. And what are the possibilities and how X-ray is reflecting it? One thing I would like to mention, that the interpedicular distance in AP view also speaks about the integrity of the posterior wall in burst fractures. That thing we have to add in the X-ray evaluations and AP view. Besides the lateral view, speaking about the various types of your angle, height of the vertebra, that also gives correlations to the integrity of the PLC. The MRI, what they are doing. Now considering all this point, nowadays these classifications, as I mentioned, the make classification, tennis classification, so many things are there, but even then they are not conclusive. Nowadays people are going for the AO classifications. What AO's classification speaks? There are basically three types of classification grading in the AO. One A, B or C. A speaks about the compression fracture, or the compression mode. It's basically based on the 3 points. Compression fractures. Number 2 is the compressions, then there is distracting force working over here. What about the compression, distractions, burst fracture, then also rotational. So there are 3 basically here, translations. So the compressions, then your integrated PLC and translations. Basically there are 3 types of your module of basic point about the AO classifications, how their basic point nowadays ABC is actually on the basis of the 3 things to classify these various types of your AO classification, which is nowadays being considered as a type of your classification universally accepted. But even then, correlationally, that important thing we are also not considering here is about the neurological status. Neurological status. Nowadays, that is why the newer concept is coming up. TLISS, or whatever is called thoracolumbar injury classification scoring systems. Basically, what is this? Nowadays, the concept is shifting on the quantifications or digitalization this thing, considering all the 3 points, then also give a directions in which way is supposed to go for the treatment. So that is why nowadays not only the fractures configurations which is important, but also equally we need to consider the neurological status of the persons, and also the integrity of PLC. These are 3 things which are coming into view to consider the patients whether they are stable, unstable, and also determine in which direction is supposed to give the treatment. So that is why nowadays quantification, digitalization and scoring systems is nowadays coming up. What is said, the thoracolumbar spinal injury scoring systems. Now it is a bit modified, which considers 3 points basically about the morphology of the fractures, how it is happening, compressions, burst fractures, translations, the scoring is there. Then also do consider about the integrated PLC structures, that also gives the scoring systems. And also you have to add the neurological status of the person, that also scoring systems. And add all this, more the score, more is the chance of instability, less is the score, less is the earn. 4 is the gray zone where you have to determine which direction is supposed to move. If it is more than 4 or 5 towards 5, then it says more instability, then it says you need to do surgical interventions. So overall the picture is that nowadays this is not merely on the basis of these compressions or the morphology of the fractures. Equally, you have to give the attentions to the neurological status of the persons. And neurological status we have already discussed while talking about the cervical spine injury, that you have to quantify the neurological status at the basis of the ASIA grading. So we know what are the things you do look for the upper limb, and what are the things you have to look for the lower limb. Also the neurological sensory of these persons from the midclavicular line, and quantify it and add it, and that way you have to grading it. Then you have to add the scoring according to the final scoring system of the LISS. So that way, that is a way nowadays to approach the thoracolumbar spine to give us the guidance and whether you should take the patients for the conservative treatment or for the operative treatment. So that is why nowadays this scoring system is coming up and is accepted for the world. And as of now, it is a widely accepted protocols of treatment of thoracolumbar spine. As you already discussed, the important thing is that while these thoracolumbar spine injury patients are coming, necessarily in a polytrauma scenario, we have to give the initial treatment on the basis of the ATLS. So giving the attention to the A, B, C, D, and finally the final treatment is there. So initial treatments protocols always is the A, B, C, D of the trauma situations. We have to give attention to all these things, and also take care initially to prevent movement at the fracture site, injury site, and subsequently evaluate the patients with the help of your CT scan, MRI, X-ray, and also the neurological status, then come to a conclusion to give a definite treatment whether we should go for the conjunctive treatment or the operative treatment. As some radiological evidence we have already discussed, give also the give a directions to conjunctive treatment about the, as we said, about the compression fractures, how it is, how up to what extent is involved. It is more compressed, more the chances of injury to neurological status of the PLC. Less means less chances. That also determines that we should go for treatment for the conjunctive treatment or the operative treatment. So, considering all this fact that this is the way we have to deal with this trauma situations in thoracolumbar spine. So far we have discussed about the possibility of the thoracolumbar, why it is more common, why there is a possibility of the more injury to the neurological structures, how we have to give the initial treatment in the casual systems or the initial treatments protocol according to ATLS. Then further evaluation of the patients on the basis of the X-ray, CT scan, MRI. Then also the importance of this calculating the scoring systems to give a guidance for this trauma final treatment of the fractures, injury. Then and finally how it is going to work in the trauma situations. So thereby we have covered up all the things, the importance of thoracolumbar spine, how we have to deal with the situations. And then the final pictures, what we need to do at the end. So this has covered up all the things which are essential to understand about the thoracolumbar spine. And if you do have any question, you can discuss the matter.